classification. This is all for PGs. Robson classification. So what is the NTSV rate recommended? What is NTSV? What classes it includes? It's all question for you. So okay, go back and read. Ideally it should be less than 10%, otherwise overall it should be less than 20%. But we all are having a cesarean section. Most of the areas are having a 60-70%. In the government colleges or a government hospital, it is around 25-30%. Nobody is having a less than 20%. And in the private, it is reaching up to 80, 90, 95 or 100%. So जो ये रास्ता समझाया था डॉक्टर रामन ने, I think he has left, कोई फायदेमंद वाली बात नहीं है. This is not beneficial. Oh sorry, I have spoken Hindi. So it's not beneficial to lungs. We should be deleting this chapter, isn't it? No. Vaginal delivery is a very good process. We have lot many ways to improvise it, and one should go for it. Being obstetricians, we have a responsibility for it. So what I had planned, this is a long thing. See, the 9-month journey have to be done so that everybody should be delivering a male or a female like Dr. Diksha, and a male like any of the males here, or so with the good IQs, good versatility. Okay, so what I had planned, I am not able to cover it in 1 hour, but I am going to touch few things to give you insight what you have to read and what is not known to you, just a concept of it. Okay, so what I am going to cover, what is conventional and modern labor curve, labor care guide and partogram. What are you using in your labor room, by the way? Partogram you are using. So I am going to touch upon this because you will have a UPT question, you will have a MCQs, you will have a short note, long note and a one. You see, management of normal labor in short and definitions and management of abnormal labor if the time permits. Okay, so why there is a need of a labor curve? Do you know, all of you? Just raise your hand. Labor curve, how many of you know? Nobody knows. I am talking of a labor curve. If you have not seen the labor curve in your Shishadri, I think Shishadri will be get frustrated. Dr. Lakshmi Shishadri, you are reading that, you are reading Datta, or you are reading what else books are there? Dr. Sheila Balakrishnan. No. You don't know the labor curve. You know who gave that labor curve? Freedmen. So we will listen to story of the freedmen. So why yesterday I also told you that to know the abnormal thing, you need to know the normal, isn't it? So for every normal thing, to diagnose abnormal, you need to know the normal, and that is the thing which is needed to diagnose the dysfunctional labor, where you have to take the patient for a cesarean section. Do you know who it is? She or he? She. Very nice. So who is she? Nowadays it is he, she, they. So she is she. So who is she? You use day in day out in gynae, in pediatrics this name. She is Virginia Abgar, and she was not a pediatrician. She was a physician and an anesthetist. Right? So this are Virginia Abgar, a nice, very intelligent lady. Ask this man. Who is this man? Emmanuel A. Friedman, gynecologist, born in 1923, passed on around in 51-52, he was a resident in the same hospital at Alabama. So what did she ask? She was working on a caudal analgesia during labor. So she asked Emmanuel A. Friedman, will you help me in knowing the effect of caudal analgesia on labor? He was a young man with a full of energy like a So he said, yes, why not? I will do it. collected data for a year, 2 year, 3 year. But he was a young man. He got married. He had a wife. And if somebody has a wife, they have to get pregnant. So her wife was pregnant. Full term. Started on labor. He asked for a loan. And what happens in the gynae department? Nobody gives leave. Nobody gives leave. He was not given leave. His wife was in a labor room in some other hospital. He wanted to go, but nobody gave him. This was a big torture. So on frustration, whole night on the 10th of June, he analyzed his data. Sat with all the papers in 1952 and he studied and did all the analysis whole night. And what he understood that night, made a chart on the relationship of contraction, dilatation and effacement. And he found that the dilatation is the most important component during the progress of the labor, which has a clear-cut relationship with the time. And in the morning, he came with one curve which was a sigmoid shape. He was very happy. He calculated and then he went off the duty immediately to that hospital because he thought my wife must have not delivered, because the finding on the evening of that was not like that. So in the morning he went and her wife delivered in front of him at 10. He was very happy. And then he gave a very good landmark paper on the relationship between the dilatation and the time. And that was known as the Friedman's curve and the labor curve, which was a sigmoid shape, and that became the basis of our labor management. So this is story you should know how the people work, and this is a labor curve in the 1952 given, and the next 15 years this man worked on this only. He is still alive, 94-year-old. So at that point of time, cesarean section rate was 1%. Instrumental delivery was quite high. But remember that today we are having a section rate of 60%, 50%, 40%, whatever it is. But at that point when this labor curve was made in the 50s, it was 1%. And this sigmoid shaped curve is called one latent phase when this is called as a preparatory phase. And then you can see there is an active phase which according to him starts at 3 cm and has got 3 phases. You can see the first phase is a transition phase, then there is a phase of maximum slope, and then there is a deceleration phase. You can get a short note on this. So the active phase starts from 3 cm, each and every point of mine is important. Active phase starts from the 3 centimeters and at around 9 cm there is a deceleration phase. Correct? So these are the components which he had given. In 1954 this was published. Later on, after 5-10 years, he has given the curve for the descent of head. Right? So descent of head also occurs and it also forms a parabola. So this was given in around 1964 and this was a landmark curve which we still study. So also known as conventional labor curve, first name, Friedman's labor curve, second name, shape is sigmoid, active phase start at 3 cm, there is a latent phase and there is an active phase. And there is a deceleration phase. All points are important. By the way, just now we have discussed how do you assess the descent of head. Somebody of you should stand and tell me. Partogram you fill up? Okay, you stand up and tell me how do you assess the descent of head. Okay, both methods you use to fill up the partogram to assess the descent of head. It is only the abdomen. Remember everyone, the descent of head is assessed by abdominal method, whether it is a ARUNA or whether it is a partogram. And how do you use this method? Tell me the abdominal method of assessment. How many finger palpable there? Abdominally, इतना बड़ा abdomen है, to keep only one hand? I will keep two hands in front of your above pubic symphysis. I have a big tummy, big abdomen. Why not? One hand only. So one hand where? Above pubic symphysis, just this much. If you want to, any time I have told you, there should be two limits to estimate. Where is the upper limit? In between what you want to assess? Yes? What can be? So, fetal head is such big. What are the limits? What upper limit you want? Both? So, what one thing you have to select? Right. So, now you understood the lower limit is a pubic symphysis, the upper limit is a sincipit. You have to put your fingers in between the sincipit and the pubic symphysis to assess the descent of it. This is called as finger method or a Christian method. Right? Okay. So now tell me, once the head is fully flexed, it has entered inside and the head is at zero station. How much head can you palpate? Zero? Well, now the question changes. If the 0 by 5 is palpable, where should be the vertex? Well flexed head 0 by 5 palpable, where should be the vertex? Ischial spine? No. Whole head is inside here. It is at the antroitus. So once you are feeling abdominally, if you want a vertex at zero station, head is engaged, it is only 2 by 5 head which is palpable. That means you are able to keep only two fingers. This concept should be very much clear to all of you. Two fingers between the sincipit and the pubic symphysis, head is 2 by 5, the vertex is at zero station. If it is 0 by 5, your vertex is at antroitus. Got this? This thing should always be very much clear to you how to palpate the head abdomen. Got it? Please be seated. 2 fifth, 0 station. 0 station. 0 by 5, head is at class 3. Head is at, and from where this fifth has come? This is a big thing. I'll discuss it, otherwise it will be too much for them. Okay, so you should be knowing from where this fifth had come. So now coming to the two components, that is a partograph and the LCG, both you should be knowing. For who has given the partograph? Who has given the partograph? Philpott and Kessel in the Harare Hospital in Zimbabwe. Okay, Rhodesia, Zimbabwe. This partograph has been given. In the year 1972, they have studied, they used the Friedman's curve and analyzed and given this latent phase. So you can see the latent phase, the straight line. No, changing is there. Laser is not there. It's not coming on the screen. It's not coming on the screen. Okay, no problem. Just look into it. So this is the first graph which has been given by Philpott and Kessel. Each and every point is important. You can get a PG question. PGs can be asked, UGs can be asked. So Philpott and Kessel, who is given in 1972, which has got a latent phase and the active phase, and then after few years they have added the action line to it, which is after the 4 hours of the alert line. So now the particle which is being used in your labor room has got no latent phase starting from the 4 centimeter and the action line is there after 4 hours. Now the question for you is, if the patient is entering in your labor room at 5 centimeters, where do you mark your first line? Where do you mark your first line? At which point? 1, 2, 3, 4, 5, x-axis, y-axis. Y-axis, it is a dilation, right? So, she has come to you at 10 a.m. at 5 centimeter. Where will you mark? Y-axis, that's the problem. So, isme hoga na, there must be. Okay, I will take an example from this. Okay, so here it is. So, where will you like to mark? Where will you like to mark? Here I should mark. Should I mark it here, 5 centimeter? Right? Everybody agrees to it. Except one person, a senior person. This is wrong. You should be marking your first mark over the alert line. If she comes at 6 centimeter, 6 centimeter at the alert line, not on the, just on the y-axis. So, this should not be 6 centimeter, it should be here. The first entry point, wherever you are doing PV, she is in active phase, this should be marked on the alert line. Remember this thing very clearly. Okay? This is a very common question being asked to UG and the PG and the ASCII question and the NEET PG question. Right? So you should be knowing, and rest are the components. There are 5 components. I hope you all should be knowing. I am not going into the detail of it. But remember that what happened? Treatment said the dilatation in general in a nulliparous occurs at a dilatation of around 1.5 centimeter per hour, and in a nulliparous it goes to 1.1 centimeter per hour. Okay? Nulliparous slightly less, 1 centimeter, and multiparous is at 1.5 centimeter. But is it applicable in a current scenario where you are having a increasing section rate? After 50 years, are you still following the same labor pathway? ऐसा क्या हुआ? What happened in so many years that we are saying that the labor path has changed? Yes, it has come into. And why it has come? Everybody said that we have now more interventions. Maternal weight has slightly increased. Lifestyle modifications are there. There is a more increase in the fetal size, maternal age, frequent obstetrical intervention. You have CPGs, you have ultrasounds, you have oxytocin use, you can use a cesarean section, instrumental delivery has increased. So we should be again looking after our modern labor curves, conventional labor curves, and it has to be reanalyzed, and that analysis has been done by GYN. So this again, one name you need to remember, the GYN who has given a modern labor curve. Right? A landmark paper came here in 2010 and repeatedly from Japan, from China, from this was a paper from America, so came, and from Africa also the studies have been done, and everybody agreed to it that there should be a change in the labor curve. And now they said we should be accepting this labor curve which is on the right side. Can you see this labor curve? Can you interpret the changes? These changes are being asked in the exams. So this labor curve, they said the active phase starts at 6 centimeter. There is no inflection point. You can see there is sudden inflection point at 2 areas, but there is no inflection point in this labor curve. Number 2nd point. Number 3rd point, if you see, there is no deceleration phase. Can you see? Observe. Yes. Say yes. Everybody is with me? Very good. So this is a concept which I am going to give. So there is no deceleration phase. There is no inflection point, and the active phase is starting at 6 centimeter according to this graph, and this has been accepted by WHO and our groups also. These are the 3 main points. which are there. And the fourth point is you can see the dilatation is occurring much slower pace, and this pace of dilatation is called as the staircase pattern of dilatation. The staircase pattern of dilatation. Then when the patient is 5 cm, she can remain there for 6 hours. When she is 6 cm, she can remain there for 5 hours. Then when she is at 7 cm, she can remain there for 3 cm. And this is the time period which has been given by the WHO that we should be following. Is not 1 to 1.5 cm per hour. So you can wait more to label it as a non-progress of labor. This entity has gone. Got it? And for that matter, in 2018, when WHO accepted all these concepts, and in 2020, they have given this labor care work guide guided by several of them, and then they said we should be accepting and we should be using this labor care guide which is there right from 2020. Remember the years? Now they say not 6 cm, active phase should start from 5 cm. Nothing in the chart, nothing in the 4, it is 5. Right? So we started from 3, we reached to 6, and now we agreed on 5. So active phase starts from 5 cm. Right? So this is the component which need to be filled in labor care guide. You can go back and see in your book. This diagram is there in your registration. And there comes a short note, good big note, all things are labor management depends on this. Don't go to the last 2 points of the difference between a conventional and a contemporary labor curve. So new labor curve being as Jan's labor curve, modern labor curve, or a contemporary labor curve. 3 names I have given you. Contemporary, modern, or Jan's labor curve. For a conventional labor curve, I have given you fragrance labor curve or a conventional labor curve. So first 4 are for you people for undergraduate, rest of the points are for PG students. So according to that you can see the sigmoid shaping, no clear inflection point according to Jan's. There are 2 distinct regions with 2 different slopes, latent and active phase. According to current modern labor curve, there is a slow progress. There is a deceleration phase according to Friedman's. There is no deceleration phase according to new. Active phase starts at 4 cm according to past, but now it starts from 5 cm, and the progress of labor is much slower as per the current labor curve. Last of the 2 points are not for undergraduates. Okay? So everybody got this? Difficult? Shall I go forward or stop here? Go. So you are enjoying, right? So now another concept which I am going to give in another 5 to 10 minutes, that what does labor care guide contains. There are 7 sections. Part of that has got 5 sections, it has got 7 sections, and there are 2 extra sections which have been added. The number is section 2 and section 7. Section 2 and section 7. And what does that section contains? One is the supportive care and another is the shared decision making. And why this concept has come? Why this concept has come? Because we need to respect our female, and respectful maternity care has to be provided to all the females with shared decision making. They should be a part of the decision. That's what we discussed while in the case of JDM, that it should be a shared decision making. Whatever you are planning for her should be informed to her, should be in consent. So these 2 sections, supportive care and the shared decision making, are the 2 important components which have been added to it. Now you can see this whole section. I am not going into the detail otherwise. So important thing, in part of that there is no second stage monitoring. In labor care guide, there is a clear-cut section here. You can see this is for the second stage monitoring. Another very important thing which has been added, you can see a blue color area here. Can you see? And what is written there? Alert column. So this has been added to this graph. And this is a very important component, alert column, where they have written down the things which should not be happening during the labor. So if something happens during the progress of labor and it is matching to alert column, this should alarm. This should alarm. So the concept of the labor care guide is assess, record, compare and plan. Can you repeat it with me? Assess, record, compare the alert column and plan. So this is a concept of labor care guide which has been given by WHO, that assess, record, check or compare and plan. Right? So these are the sections which are there. You go back and read each section. Your postgraduates will teach you, taking one each. So here I would like to just wait a minute. You can see this section 5 contains many things. Feature monitoring and maternal monitoring. Can you see? Is it visible to all of you? Just look into the first section and I would like to ask you, how do you monitor the fetal heart rate during labor? So somebody says cardiothoracic, somebody says intermittent auscultation. So how many of you say intermittent auscultation? Yes. Very good. So intermittent auscultation or CTG analysis? What do you want to do? Yes, perfect answer. If the patient is a high risk, you should be going for a CTG. Otherwise, intermittent auscultation is more than enough. And how do you assess the fetal heart rate during labor by intermittent auscultation? How do you assess? Put in a step and listen to it. What do you listen? How do you see that there is an acceleration? How do you see that the fetal heart rate has dropped? How do you see that it is regular or irregular? How do you say during intermittent auscultation that this heart rate is regular or irregular? Last question. This question will be answered at the end of the session. Okay, so we have talked of descent, we have talked all this. So this is a shared decision making. You have to plan, assess and write down if the patient agrees to your things or not. So this finishes most of my labor management. If the question comes to you labor management, you have to write down the partograph component of it or a LCG and a component of it. Right? So just hurriedly, if the full question comes to you on a management, how will you go about it? Right? So these are the components which have to be mentioned during your answer that we are going to manage our labor in this manner. Have you ever seen anybody counseling to a patient that you are going to have pains during labor? Or is it only the mother-in-laws come and say, "Beta pain to hoga?" You will have a pain. Tell me. Any doctor says that you will have at 4 months time or a 6 months time during antenatal checkup, we say that pain will be there, you will have to tolerate, or there are methods by which I can decrease the pain. So there is no antenatal education regarding the pain or the management of labor. Right? So that should be done. We don't have a counseling for more 9 months and suddenly the patient drops in our labor room. And we say, okay, pain to hoga. You will have to suffer the pain. No, we should be having a proper counseling for whole 9 months that you are going to have pain. And the couple also, the family also should be counseled. So antenatal education about of labor has to be there. Then there is a latent phase of labor in which only nibbling pains are occurring. So what has to be done during that period? We should be delaying the admission. Some amount of counseling is needed. Education, support, good hydration, position of comfort and non-pharmacological methods should be used during that time. If the patient presents to you with a pre-labor rupture of membranes, that is leaking per vagina, before labor, after 37 weeks. So what has to be done? You just counsel her, wait for 12 hours. So there are different school of thoughts, but ultimately these patient goes into labor in next 6 to 10 hours. So you should be waiting for 12 hours and then inducing her, you can augment the labor at that point of time. Continuous support, that is the section 2 of the labor care guide. Continuous support, one of the family members should be allowed to remain with the female, and whether it is a husband, mother-in-law, whosoever she is comfortable should be allowed. Right? So continuous support during labor has to be there. What is the role of the routine amniotomy? Routine amniotomy. Shall we go for it? Amniotomy means amniotic rupture of membranes. So this should be delayed as soon as possible, and there are certain indications when we are going for amniotomy, that is, if you suspect a fetal distress, meconium stain lichen, you suspect that there is an abruption or previous cesarean. These are the indications where you can go for a early rupture of membranes. Otherwise, this back of membrane is causing a good dilatation of the cervix. So it should be delayed as far as possible. Then comes the intermittent auscultation. I have already told you, so LCT should be followed. Techniques of coping with the labor pains. This I have enumerated. You can just click a photograph of it. So these are the techniques which can be used for a labor pain management. But the best way, proven way, is to provide the epidural analgesia. The best way. Perineal massage has also been quoted as a good method, but there are other methods which are in studies. You say, you don't say, but these are just in a practice. You can do something you need to do with the patient in labor, right? Say hydration and oral intake should be allowed throughout the labor. She should be moving around in the labor room as far as possible, except in few conditions. And in which conditions she should deliver? Standing, sitting, lying. What condition do you think is suitable for her for a delivery? Whatever position she is comfortable, she should be allowed to deliver. It is not that in which doctor is comfortable. Should we give episiotomy in each and every case? Episiotomy is not indicated in each and every case. Whenever the perineum is tight, you are going for an instrumental delivery. You want slightly faster, only the indication. Otherwise, even in a primary, it is not indicated. And what should be the angle of episiotomy? Why do you want a 60-degree extension? You want to prevent the extension to anal canal, to give it 45-degree. What is the harm? Why do you want to have chosen the 60-degree? It becomes 45-degree, so again it is 45-degree, then it becomes a 20-degree. Again it is still away from the anal side. Why do you want to give it at 60-degree? Comes it is 45-degree, very good, 20-degree less. Then why? You see, the concept is when there is a full dilatation, head is at the perineum at the time of the crowning, when you are giving a episiotomy, the total thickness of the anal sphincter comes to be 2.5 stage of labor. What is the duration of the second stage of labor? What is the duration of the second stage? In this you should remember first stage, second stage. No. So do cesarean section in each and every case. 8 hours, second stage. Through 3 hours for a null parents, 2 hours for a multiparents, and if you are using a epidural, add plus 1 hour. This is the second stage duration according to the current guidelines, and previously also it was a 2 hours and 1 hour. So there are not many things which you need to learn in the labor. The management of third stage, you cannot skip it during your final year exam. Management of third stage, active management of third stage of labor, and here I will end because I am not going to cover the abnormalities of stages of labor. Thank you all. I hope you would understand. Just one thing I want to cover. So if you want to understand few of the things, so can you manage normal labor? Can you make right diagnosis of labor abnormalities? No, madam has not taught. So you can't do this. So conclusion I am giving. So this is my website. If you want to understand the labor, prepare for your exam, you can go to my website and you will never find a mechanism of this is especially for all the undergraduate, postgraduate, mechanism of normal labor if you want to understand. Every this module have got 20-30 lectures of very good quality, and all the concepts which I am trying to give you is given in the details. So these blue ticks are for undergraduates. So these 4 are for you, along with this 7 quick revision table by now. And this red ticks are for postgraduates. Right? So all obstetrical surgeries, gynae surgeries, practical case discussions are there for you. So you can go to this website and look after it, or you can message me, or you